Other people on the dais will be joining us very soon. We have a very, very eminent list of speakers here. We're going to talk about all the possible permutations and combinations of refractive surgery and the pros and cons of each. We have none other than Rajesh Sinha, who needs no introduction, to talk to us about choosing the right refractive procedure in 2023.
Thank you, sir. A very good morning to all of you. I'll be talking about choosing the right refractive procedure in 2023, that is in current scenario. And in current scenario, we have cornea-based refractive procedures and lens-based refractive procedures. The cornea-based refractive procedures are LASIK, SMILE, surface ablation, and ring segments. Lens-based refractive procedures are phakic implants, refractive lens exchange. We started long back with surface ablation, the first of the procedures, wherein epithelium is debrided and then excimer laser is put, and it results in change in shape of the cornea, and that is how it works. Then came microkeratome LASIK, when a flap was created with the help of a microkeratome, and then once the flap was created, it was lifted, and the stroma is ablated, and that is it. Then came femtosecond LASIK, wherein the flap is created with the help of a femtosecond laser, and rest of the procedure remains the same as a microkeratome LASIK. Lift the flap and go ahead. And then, of course, came the SMILE, which is gaining fast popularity, and wherein instead of ablating the stroma, we just remove a lenticule, the stromal lenticule, and by dissection, and it's all femtosecond procedure. And of course, intracorneal ring segment, which was first approved for low myopia in FDA, wherein it causes an arc shortening effect. We create a track for this ring segment, and then we place it in position. Lens-based refractive procedure can be phakic implants and clear lens or refractive lens exchange. So in clear lens, in phakic implants, the implantable Coulomber lens is the most popular lens that is implanted behind the iris in the sulcus in order to correct for the refractive error, and that's how it corrects the refractive error. So with these things in mind, we the first interact with the patient, and the interaction includes what's the motivation, how much is expectations, what is his what's his age, what's the amount of refractive error, whether the refractive error is stable or not. What is the ocular surface? That's again important because that has a lot of bearing on the outcome of refractive procedure. What's the keratometry? How's the topography and the tomography? And the topography and tomography is basically done to rule out suspicious corneas. So based on placed topography, these are some certain criteria wherein you can detect a suspicious cornea. And based on Scheimpflug photography, we can, based on the curvature map, based on the elevation map, and of course the thickness spatial profile, we can detect suspicious corneas. The PPI max average should be less than 1.2, ART max should be more than 391. And the Bellin-Ambrosia enhanced ectasia display displays the subtle changes that can be seen in early keratoconus. And if you don't find anything, you can also do an anterior segment OCT, which can give you the earliest finding in terms of thinning of epithelium in the inferior and inferior nasal or inferior temporal part. And that is how we detect. And once you are deciding about the how much the ablation you have to do, there's a cutoff of percent tissue altered of 40%. It should be less than 40%. That is flap thickness plus ablation depth divided by central corneal thickness. And the aim for keeping a post-op keratometry should be between 34 to 48, otherwise it will create a lot of aberrations. And of course, the anterior chamber depth, if we are planning for phakic implant, should be good with an open, should be more than 2.8 with an open angle and with an angle recess of more than 35 degrees. So we have these options and we have to take a decision. As far as ring segment is concerned, it was approved for low myopia, but these days there are better options for low myopia. So we reserve it for post-LASIK ectasias. And also in some cases of primary keratoconus, when the patient is not willing to use contact lens, then some amount of astigmatism can be reduced by ring segments. And then of course you can also place the phakic IOL to correct the remaining refractive error. It also depends on the occupation of the patient. If somebody is in contact sports, then flap-based procedure should be avoided, and we can do smile or surface ablation. So based on the literature, based on all these our own experience, we followed this guideline that if there is a myopia of less than 8 diopters, hyperopia less than 5 diopters, astigmatism less than 4 diopters, and pachymetry enough for RBT more than 300 microns, keratometry between 40 to 46 diopters, and PTA is less than 40%, no evidence of keratoconus, we can go ahead with LASIK or SMILE, anything, microkeratome LASIK or FM2 LASIK. But if the cornea is steep, we should avoid use of microkeratome because it can cause buttonhole. If the cornea is flat, we should again avoid microkeratome because it can cause free cap. And the surface ablation can be done using mitomycin C. And if the RBT is less than 300 microns, if there is large amount of refractive error, in such cases we can use phakic implants. If there's some residual refractive error left after phakic IOL, we can also do a surface ablation or a cornea-based procedure. And definitely last but not the least is an option of a clear lens extraction particularly in patients who are in presbyopic age group. So I'll just show 2-3 case scenarios and I'll conclude. So a 24-year-old male with a refractive error of -4 diopter sphere and -1 diopter cylinder, RSBT 362, 371, residual K is also fine, PTA is less than 40%, maps are all good, no evidence of any keratoconus, we can go ahead and do a cornea-based procedure, LASIK or SMILE. Another scenario, a football player with similar kind of finding, we should better counsel the patient for SMILE if he has come for any refractive procedure. Then, of course, alternative is PRK, which can be done with mitomycin C if you don't have the facility of SMILE. And if another case scenario, 21-year-old male, -9, -10 diopter sphere, RSBT is 236, 221, PTA is high. Even if the map is fine, you should counsel the patient for phakic implant. A 21-year-old male, very high refractive error, 26 diopters, 22 diopters, RSBT, PTA not within normals. Even if the map is okay, you should counsel the patient for bioptics or the Indian phakic implants, the acrylic ones, they can be customized and they can be implanted. And the last scenario, a 55-year-old male with -10 diopter sphere and 2 diopter cylinder. Endo-SED is also less, it is 2.5. Can't put a phakic implant. In such cases, you can, if the patient is willing for it, you can counsel the patient for a refractive lens exchange if the patient is motivated. So in conclusion, refractive surgery to date is not just a cosmetic surgery because heavy dependence on glasses reduces your quality of life. And in order to improve quality of life, refractive surgery has to be done. Like somebody who is having a 10 diopter, 12 diopter of myopia, his quality of life is very much compromised. So in such cases, it's not just a cosmetic, rather it's a therapeutic procedure in order to improve the quality of life. But patient evaluation and understanding the fitness of a patient is most important. And decision not only depends on the parameters, but it also depends on the demand and the occupation of the patient. So thank you very much for your patient listening.
Thank you, Rajesh. Are there any questions from the audience, or would the panel like to speak to Rajesh?
Yeah, I think it's very important to select the right procedure, and pre-op selection of the right procedure for the right patient is very important. Sure. I think assessment in refractive surgery plays a bigger role than doing the actual procedure, and that's why it's a very important talk. And if you know questions for Dr. Rajesh Sinha, it's my pleasure to invite Dr. Rohit Shetty, who will be talking on collagen imaging and its role in refractive surgery planning. And this is a very new topic. Many of you all may not be familiar with it, but they have a polarizing OCT where they can actually image the collagen fibers for screening and planning refractive surgery. So it will be very interesting to listen to his work using the polarizing OCT and collagen imaging.
Thank you, sir. And talk is the imaging the collagen. These are my financial grants. I don't have any direct link to the presentation today. The evolution of refractive surgery started with different technologies, and that involved different indices. And every new year, we come out with a new indices which says that that's going to be better than the previous ones. But the challenge is still we are falling short, even though when we publish, the sensitivity and specificity of a lot of them, including pentacams, close to around 90-95%. And all the senior refractive surgeons in this panel here would agree that most of the ectasias they get or the challenges they get at once where they had a normal indices. So that becomes that suddenly you start rethinking about those sensitivity and specificity of these things. And times when you have done cases on topographies which probably would not have dared to do it today with all these indices in the what you did it in the past, you feel that they are the ones who are doing very well. So this whole challenge makes us to understand that there has to be something else, and the biomechanics makes it even more confusing. And there are small skiving, there are biomechanical changes. Sometimes there is skiving and there is no biomechanics changes, and the indices in both these cases could be normal. So we also have challenges when we do, say, cross-linking or smile extra and these procedures, when we don't know why some patients do very well and some patients actually fail. And there again, we need indices or things which can predict what is really happening. So what we thought is when we build this polarization OCT, which is looking at the collagen fibrils itself directly, what you normally see on a histopathological aspect of it. And the reason is it was important is that we need to understand the fibrils. We need to check at real time what is happening to these fibrils. We need to look at the layer of Bowman's. We need to look at every structure as it is based on what a histopathological aspect of it or what we are born with. So these are the existing modalities of it. Confocal microscopy does not give it, the resolution is not good. Scanning electron microscopy is not possible on a live imaging. And what we thought was, if we are using the principle of a polarization OCT, and that's what we thought we would like to build in. And there is a huge knowledge gap, which I already mentioned. And it took us close to 6.5 years to work on this and come out with this prototype machine where we are able to look at the properties of the collagen and using the birefringence properties what we are aware of. What's interesting here is this is still a prototype, but we are in the process of making it commercial. It is the finest resolution possible on any OCT, humanly possible. It's close to around 1 microns. Importance is if it becomes less than 1, which is our vision and dream this year, then it becomes adaptive optics. Then you can see every cell on your cornea, keratocytes. From the retinal point of view, you can even see the rods and cones. So the whole idea is to bring it less than 1. For that, the adaptive optics has to be fit in. And the best OCTs today, let's OptoView or Heidelberg, is still around 5 microns. So that's the resolution change we are. The important thing is that every layer by layer, including Bowman's has a resolution in pixels of around 2.5, 3 pixels. So because of that, your resolution has to be so good that you should be able to pick up and map the Bowman's. And stromal thickness and every other layer can be checked. And this is your Bowman's layer. You can map. Bowman's topography itself can be planned. And Bowman's, we all know how important it is, especially in these practices when, along with epithelium, this is one of the first layer to become thinned out. And the collagen fibrils suddenly start becoming more clear because, the darker the shapes, your more tighter orientation, the properties remain stronger. And these are your peripheral anchoring fibers, which you can do. It just takes around 1.5 minutes to image both eyes, and now we have our own software. Now, how does it help? It is that this is normal. The checkered pattern is perfect. The peripheral fibers are healthy. In a case when you see that is suspect, you can see that this lighter turquoise blue means that you have lost the collagen there, and there's only central island left, and the peripheral fibers, anchoring fibers, are also weaker. And every grade of keratoconus, irrespective of grade on your topography, you have different functions on the corneal plane. And very interesting feature here is that we can start looking now at different layers. That means you start at 90 microns, 100 microns. Your collagen imaging can be at every layer. You can just go by around 2233 microns. And this is very interesting. You can just see the smile and the PR case, the pre-op and post-op. The smile has a small change. The LASIK, the huge amount of change in the collagen at depth below 130 microns. But PRKs, especially in those cases, PRK to begin with had very poor collagen. And that's the reason you do PRKs, and you hardly see any change in the collagen. And this is pre-op smile, and post-op hardly we see changes in the collagen. So these are direct proof that when you do procedures, different procedures, and how much does it actually affect your collagen. So in nutshell, the collagen imaging is going to change a complete new dimension. And I keep quoting Dr. Sri Ganesh's paper, and he and Sheetal Brar had that big number of series of Smile Extra. But when you have a clinical paper, you need proof. And recently I was presenting in the Smile Users Meet that the collagen changes after Smile Extra was completely different compared to what you do with just Smile. So just that when most of your clinical data needs proof, and all that you've been doing, the imaging the collagen helps you to get that proof. And this is a non-invasive technologies, and maybe next year the same technology will be able to image the keratocytes, many cells in your cornea, and every layer would have different patterns to it. And this is a big biomarker, maybe even in planning procedures. And also sometimes when you have these unexpected outcomes, especially in cross-linking, when you get a scar and other things, excessive collagen, if you have, and you do a cross-linking on it, you get scarring. This is what we have noticed. And this also can help us to decide when we need to do a LASIK or a Smile Extra, or you can just ignore it in spite of corneal topography being abnormal. And we are working with 2 companies, and a lot of OCT companies are interested because they want to, this will be the way they would look at the next version of OCTs on this. And this is the fibril orientation. Now, this is a software we built which looks at the complete fibrils as it is from the corneal plane. Thank you.
Thank you, Dr. Rohit. Very interesting work that you are doing. I think this is more significant for countries like India, where our average refractive surgery patient's age is around 26 years, compared to the Western countries where it's 36. And we all know that with age, the collagen changes and gets cross-linked, so it's a little stronger. So probably the risk of ectasia in countries like ours, where we are treating a very young population, would be much higher. So that's where devices like this can provide us insight where we are actually able to image the collagen.
And like I said, your work on, excellent work on Smile Extra, when we started doing this, where we did a randomization, it exactly proves what you have written in your conclusion, in your discussion, that, it biomechanically changes, and this is a proof. So whatever we say, we need proof, and the proof is when you see this image, like I showed, those orientation completely changes.
So what do you think would be the cost? Because now we have so many devices for pre-op assessment, so it's becoming, the pre-op assessment itself is becoming more expensive.
So it will be cost of your OCT or topographer. It should not be more.
It should not be more.
Because they just need to have a different hardware. It's better for them, because with the present hardware, they're not even reaching 5 microns resolutions. Yes. This is going to 1. And if you add adaptive optics, it's becoming costly. But that's why Oculus is very keen, because all the companies which wants to make the new OCTs are very keen on this. So I have no doubt that this should be, in the next generation of OCTs, this will be the source of light.
Many of the institutes have confocal microscopes. Is there any way to image collagen? No, it's very difficult. You can see cells and...
it just looks at the cells because the resolution is poor.
Resolution is poor.
And no way you can measure it. So the only way to measure is the scanning electron microscopy, but that's not possible. It will burn the whole eye. The second way is the non. It just takes exactly 95 seconds per eye, and software is, we have only developed it. So, but I'm sure the companies will do their own as we go on.
Congratulations.
How sensitive and specific would be the...
We just published in JCRS. It's very high, close to 90%. Repeatability is very good. It was just published 4-5 months back.
And is it going to be like a whole new language, or anybody can interpret the data
Anybody can
that is
interpret
given?
it. I just showed you. It's just color-based.
Thank you.
Thank you.
Thank you. It's my pleasure to invite Dr. Chitra Ramurthy. He's a very prolific refractive surgeon, and she does all the refractive surgeries, and she'll be speaking on customized lasers for myopic correction.
A very good morning to one and all of you in the audience and my dear friends on the panel. My due is to talk to you on customized lasers for myopic corrections. We all know that there are different kind of ablation profiles, right from the earlier plano scan to the present day topo-guided treatments to 4CDs. We also know wavefront is created by the reflected wavefront which passes through lenslet arrays, captured by the CD camera and gets the CCD image. And what you see can be defined as the lower order aberrations and the higher order aberrations. The lower order is the sphere and the cylinder, and the higher order aberrations are mainly the trefoil comas and the spherical aberrations. We also know that the spherical aberration is caused because the central rays and the peripheral rays do not come to one point focus, and this is what is causing the dispersion of light. We also know with the excimer laser, the light which is passing directly to the light which is passing obliquely allows a lesser ablation profile, so because of which the spherical aberrations are caused. So in the conventional laser, which was happening earlier on, we had more positive and negative spherical aberrations, whereas so they moved on to wavefront guided, which was information collected from the aberrometry, and all the aberrations of the eye were treated on the cornea. But then it did not treat the aberrations which were created by the treatment. So why we also know that the spherical aberrations are caused by the laser being attenuated in the periphery of the cornea. So the wavefront optimized came such that it hit some extra spots of laser, gave it a more aspheric profile, so that the spherical aberrations which were induced were not created. So then, at that point of time, there was more evolution and the topo-guided treatment came, mainly to repair the bad corneas. It was essentially a combination of a central myopic and a mid-peripheral hyperopic treatment, which helped in correcting the sphere and the cylinder. It functioned like the wavefront optimized to remove the spherical aberrations, but it also treated the aberrations on the cornea. So then, why was it that you are still talking of topo-guided against wavefront-guided? Because that is also customized, but therein there is more tissue which is removed with the wavefront-guided to make a planar wavefront, whereas with the topo-guided, it is just flattening the peaks and lifting up the mid-periphery of the cornea. The huge advantage with topo-guided is there are a lot of measurement points, lot of peripheral data is corrected, and after all, the aberrations are more on the cornea and the topo-guided treatment is treating on the cornea. So then what is specific to topo-guided? If topo-guided treatment could be used for abnormal eyes, why can it not be used for normal eyes? And that is how contour vision evolved. To correct the sphere and the cylinder, to correct that induced spherical aberrations created by the laser, to correct the small irregularities on the cornea on the topo-guided mode, and it was best of the both worlds. Of course, there were some indications above -9, up to 9, up to 3 diopter cylinder and all that. So you need to plan, choose the ideal maps and feed those ideal maps into the computer such that the laser ablation would correct the refractive error and also the aberrations which are there existing on the cornea. But the indications for topo-guided treatment was that the topographic astigmatism and the refractive astigmatism should be nearly similar, and also the ablation profile needed to be similar. So for example here, for a refractive correction, it needs a 36 micron. For the small aberrations which are there, the trefoil, to get corrected takes 6 micron. And the final ablation profile which the topo-guided treatment demands is this. But it should compare with the refractive profile, and you can see they are nearly similar. So these are the ideal cases wherein you can do a contour treatment. So you need to analyze the results, and Stuttling et al. Found that there was a gain in visual acuity in those patients who had done a topo-guided treatment. So Alcon decided to go ahead and further analyze the results, and what they found was 90% of them had 20/20, but there were more who had 20/16 and 20/12. And also the quality of vision during night time and reduction in glare was phenomenal. But then FDA compared it seemed now important that we compare this FDA results with the exponents of that time, that is Canelo-Ponis and Lebanov. What you found was up to 2020 it was okay, but at 2015 only the FDA results were good. Why was it good? Because FDA tests chose eyes wherein the manifest refraction and the topoastigmatism were very close. The magnitude and axis difference was very less, and they chose near normal eyes with very minimal topographic abnormality. So then, Canelo-Polis said, when you are treating on the cornea, you need to take the values of the topography and the axis and the magnitude. But then there were some eyes where there was a lot of difference between the refraction and that on the topography, as you can see in these maps. So whenever you're treating the aberrations, we need to understand that there is going to be a refractive impact which has to be corrected. So then these were some examples which I'm showing you, wherein there is a difference in the topographic axis and the refractive axis, and the two to guzzle up on the topography, it nearly needs 8 micron, that is nearly a 3/4 of the diopter. Similarly, in the second map, these are those small gray areas wherein you are not sure whether you do a contour, because there is some kind of a refractive impact by correcting more aberrations than normal. So then, keeping this in mind, the different studies were done, and what it showed was that doing based on just topographic refraction and axis was definitely not superior to doing it on the manifest. Why? Because the topography was only looking at the anterior cornea and not at the posterior cornea and the internal astigmatism. So again, we compared the FDA results with the topo-guided treatment mode with Canelo-Polis and Lebanov, and again, the FDA results were superior. So why the difference? As I said, it was assuming that all the cylinder is on the anterior cornea, and which is not. You might make the anterior cornea perfect, as in this map, but then there is some. So we also analyzed some 30 of our eyes, and we found that only in 30% of the eyes, actually, the uncorrected vision was better. So were the other results. So then it made you pause. That do we do half the topographic axis and magnitude? Or, so there were some prospective results, Rohit and et al. They did a contralateral study of 60 eyes wherein they showed that the contour results were better. This was another Canelo-Polis study of 44 eyes, which again showed that the contour predictability and sensitivity was better. So what we realized that we needed to have a more analytical approach where you account for all the astigmatism, anterior, posterior, internal, and also realize that when you are treating the aberrations on the cornea, there is a refractive contribution which has to be corrected. So then Lebanov came with the 4CD software, wherein he ensured that all these measurements were taken, and each of these measurements, their impact on the cornea was assessed. Sometimes this amount of aberration, as is shown, can induce a lot of refractive impact. That has to be compensated in the spherical equivalent. Sometimes if you're looking at the aberrations at the periphery of the cornea, to remove it, it is going to have a hyperopic effect. So that means you have to introduce some myopia in the spherical equivalent. And so he did a vector analysis based on the values of each anterior, posterior, internal astigmatism, and the talus or the higher order aberrations. And then he analyzed his results, which showed that the 4CD was better in 70% of the eyes. There was a 1-month study which compared with FDA, which showed that the FDA results and the Lebanov results were actually good. That means an analytical approach was the way to go. But having said it all, I'm going to show you 2 small examples. In this patient, one eye smile was done, other eye contour was done, and the refractive map and calculation. This was the right eye with smile, doing brilliant. This was the left eye with contour, doing brilliant. But then, in the left eye, there was a flipping of the axis. The patient had 0.75 in a different axis than it was initial, and somehow the patient was not too happy. This was just one-off. And what Fosidi said was there should have been a better analysis, and there should have compensated in the spherical equivalent, and subjective refraction would have been better. This was our results where when we compared SMILE and Contura in 200 eyes. We found that the safety-wise and the efficacy-wise, they were nearly similar. But what came to light was that the residual error was actually less in Contura. The cylindrical correction was better in Contura. And another surprising thing, which I myself couldn't accept because I do a major amount of SMILE surgery, the improvement in BCA was better in Contura than SMILE. But then it's just 200 eyes. So what we have to conclude is, when we are doing SMILE, we are creating an aspheric lenticule. It has a larger optic zone, smaller transition, less of spherical aberration. It is centered on visual axis. It is forgiving for small decentration. There's less cutting of nerves. We know by many studies that regression is less. But Contura has more measurement points which augurs for greater accuracy. We have newer nomograms which measures the total astigmatism. Higher astigmatic corrections are gratifying. You could do on the flap-based mode, you could do surface ablations. So then, what we can only conclude from this is, each of these technologies are good. They're contemporary, competitive technology with their own sturdy results. And we should be selective in our patients, look at our outcomes, and choose whichever procedure we want. But it is most important for us in our practice not to blindly follow what the other person says. Understand each procedure and what best it offers and use it optimally in your patients. Thank you very much.
Thank you, Dr. Chitra. I just had one question. When you compared the astigmatic results of SMILE versus Contura, in SMILE, did you use cyclotorsion compensation?
The manual.
And did you use nomograms? Because again, for the cylinder correction,
nomograms are created based on your post-operative outcomes. You devise a nomogram. And in our particular machine, over 10 years we've been doing SMILE, and we were constantly getting good results. Some unexplained small astigmatism. We have corrected even up to 3 and 4 astigmatism in SMILE and had great results. But there was some eyes which had a small errors. The thing in Contura, in that 200 eyes, we have done so much in each now, in that batch of eyes, it appeared that the Contura was faring better in higher astigmatic errors as against SMILE. So in our practice, what we do is, we definitely give all the 3 options to our patients. We even give surface ablation, everything. We explain to them which would be ideal, but we have slowly slipped into higher astigmatic corrections. We do Contura. The others, we actually guide the patient and leave it to their choices. They are contemporary good technologies.
Yeah, if you use the nomograms and then cyclotorsion compensation, we find that the results are better than LASIK with SMILE. The long-term results, because the stability of the astigmatic correction is better in SMILE than with LASIK. So that's what we have found.
Yes, I'm sure.
And not needing to make a flap, and also not depending on the surface ablation's healing response. I think SMILE would still score equally well.
Actually, with the present ablation profiles, I don't think we have residual errors in even surface ablations, unless you are going to transgress and treat too high a refractive error on the cornea. Like, each of these procedures are doing very well.
Thank you, Dr. Chitra. And it gives me great pleasure to invite Dr. Sri Ganesh, who needs no introduction. He's the most prolific cataract and refractive surgeon of our country, with international and national repute. And he's going to be talking about hyperopic SMILE and Visumex 800.
Thank you, Doctor.
I think that's his forte.
She is basically the mother of SMILE, who actually first introduced SMILE in India and internationally. I have changed my topic because I don't do much of surface ablation, because in the program it says surface ablation, but I hardly do surface ablation. So I would be talking on an interesting topic which we have been involved in, which is hyperopic SMILE. I am a consultant to Carl Zeiss Meditech. So the initial lenticule profile for hyperopic flex, and this study was performed by Walter Secondo, where they did a feasibility study on 9 eyes, and they used a transition zone of 1 millimeters, 1 millimeter, and the minimum thickness was 25 microns in the center. So this was the profile where it is thinner in the center and thicker in the mid periphery, and you remove more tissue in the mid periphery, similar to how you do with LASIK. And with their hyperopic flex, the predictability was 70% within half a diopter and 89-90% within one diopter. So there was also, they found that there was quite a bit of regression because the transition zone was just 1 millimeter, and this was published in 2018. The Nepal hyperopic smile study, which used larger optical zones and transition zones, they used an average of 6.5 millimeters zone, and they treated a mean spherical equivalent of plus 5.73, which is fairly moderate to high hyperopia, and it was a younger population. And they published their results in the Journal of Refractive Surgery, which showed that they achieved good centration, and 6.3 mm zone with smile corresponds to a 7 mm zone with LASIK. So you get relatively larger zones with hyperopic smile than LASIK, and so better stability. And this was the first multicentric approval study, which is finished and submitted for CE approval. And there were 8 investigators from all over the world, and the principal investigator was Walter Sukindo. And our hospital was one of the sites for the global trials for hyperopia. So in this multicentric trial, we used a M size pack. You can't use an S pack because you have a larger ablation zone. The white to white had to be more than 11.5 millimeters. We used an optical zone of 6.3 mm, a transition zone of 2 millimeters. Central thickness was 25 microns, and the cap was 8.8 to 8.9 mm, and we used a 120 micron cap, and we used an incision of 2 to 4 millimeters, and we used lower energies. The average energies in the centers were between 26 to 27. Inclusion criteria were patients with hyperopia or hyperopia with astigmatism, and the predicted post-op K should be less than 51 diopters. Pre-op corrected vision 20/25 or better in each eye treated. And we treated a total of 374 eyes, 199 patients, average age of 38.8 years, and almost equal distribution of the gender. Attempted hyperopic sphere correction was plus 2.76, but the range was 0.25 to 6 diopters. Attempted refractive cylinder was 0.88 to 0.87 on an average, but the range was 0 to 4.75, and spherical equivalent attempted was 3.20, and the preoperative minimum corneal thickness was 544, and the pupil size on an average was 4.9. So if you look at the safety, again in total 9 visits were required, and these patients were followed up for 12 months. If you look at the safety index distribution, immediate post-op, there is a little less in the safety index, but at 12 months the safety index was at 1, which is quite good. If you look at the contrast sensitivity, again there is a little bit of drop in the contrast sensitivity when compared to the pre-op, but still it is within the normal range. Coming to the efficacy, you can see that 88% of the eyes had visual acuity of uncorrected visual acuity of 20/25 or better. So that is quite good for hyperopia, and 68% 20/20, 6/6. The safety, if you look at it, 77%, there was no change in the best corrected vision. 11% lost 1 line, and 1.2% lost 2 lines. And about 10% had actually a gain in 1 line. This is the predictability, which is the spherical equivalent attempted versus achieved, and you can look at the scatter, and most of the eyes were within 1 diopter almost, but there were some outliers. And if you look at the post-op spherical equivalent refraction, 81% were within half a diopter, which is good for hyperopia, and 93% within one diopter. And we found that there was increasing undercorrection over plus 3 diopters of hyperopia. So we need further nomogram adjustments. If you look at the stability over 12 months, you can see that only 9% had a change of more than half a diopter. So even after 9 months, there is some amount of small regression, probably because of the late epithelial healing. But what we found that the stability is quite good. It stabilizes by about 2 months, 3 months, and then it is fairly stable with slight regression, late regression. The stability, in fact, when you compare it to LASIK, is better with SMILE. If you look at the astigmatic correction, 75% of the eyes were within half a diopter and 93% within one diopter. And even patients with over one diopter cylinder were well corrected. So basically, the results of the global multicentric trial were much better than the previous hyperopic flex and the Nepal SMILE studies. Marginally better refractive outcomes than the hyperopic femto LASIK with MEL 90, which had 73% within half a diopter and 93% within one diopter. There was a higher incidence of a transient haze compared to myopic SMILE. So with hyperopia, you have larger zones, and we found that the haze was slightly less, but it was transient. And the recovery is slightly slower compared to a femto LASIK for hyperopia. But what we found is there is less regression in hyperopic SMILE than hyperopic LASIK. So the CE approval for SMILE should happen anytime within the next 1.5 months. And what we learned from the study is that you will have to use an M-size pack. And sometimes you have smaller white to white in hyperopic eyes, which is difficult to treat because the ablation goes up to the limbus, and it can be difficult to dissect. Longer treatment times with the 500, almost 35 seconds. Suction rate loss for hyperopic SMILE was 0.7 when compared to myopic SMILE, which was 0.3. The suction loss in the multicentric trial was 1.34%. With the Visumax 800, it is 3 times faster, and you also have tracking for centration and cyclotorsion. So the results will be better, and they're going to make the hyperopic SMILE available only on the Visumax 800, and it should be available commercially in the next 3-4 months. So to conclude, integration of hyperopic SMILE into the new Visumax 800 will provide an excellent option for laser vision correction of hyperopia and hyperopic astigmatism, and this we should see in the next 3 to 6 months. Thank you very much for your attention.
Excellent talk, Dr. Sri Ganesh, sir. Sir, you're talking about the hyperopic SMILE. I think initially what I know that you started the study with the Visumax 500 for hyperopic SMILE. But that what you are showing about the time, that is around 34 seconds. Even with the Visumax 800 also the time is same for hyperopic?
No, for hyperopic it will be within about 18 seconds.
18 seconds.
So
only with the Visumax 500 it was around 34 seconds. So chances of suction loss was quite high, like 1:150. That's what you are showing.
So that's why the company has decided to make it available only on the 800 and not the 500. Yeah. The hyperopic SMILE.
Would you suggest to do in any hyperopic cases done on the cornea an extra procedure to have better stability over a period of time?
Yeah, for younger patients, we prefer, because younger patients, regression is more because of the epithelial hyperplasia and also the corneal biomechanics. In SMILE, the corneal biomechanics are better than LASIK, so that's why we see less regression. But if you add a cross-linking, then probably it will be that late regression will be less. And so we probably need to do studies where we combine cross-linking with in hyperopia, hyperopic SMILE, and look at the long-term results, especially in young patients.
And which refraction are you considering when you're treating hyperopia?
Pardon?
Which refraction? Is it the dilated manifest refraction?
We look at the dilated...
and which cyclopegia do you use?
We always do a cycloplegic refraction because many of these young patients accommodate, and there is a nomogram.
So which cyclopegia do you use?
We use cyclopentolate.
Cyclopentolate.
We use cyclopentolate because in the younger patients, It's very important to paralyze the accommodation. Otherwise, again, you can have undercorrection if you don't do that.
And do you use the full cycloplegic refraction even in younger patients, or do you tend to undercorrect slightly? Or
No, we use actually, there is a nomogram which actually overcorrects because of the regression. But even using that nomogram, they found that there is some amount of late regression. So what happens is when we, in these young patients, when we use the nomogram, initially we see that they are a little overcorrected, but by about 3 months, they kind of stabilize.
so that's a very important take-home point, that in hyperopic correction, you do initially expect that the accommodation will take some time to relax. So if they are overcorrected or apparently overcorrected, you should not get scared and you should
So
wait
many of these patients,
at least for 3 months.
many of these patients, immediate post-op, they say that distance vision is blur. They keep complaining that the near vision is better, but the distance vision is
They
blur.
may sometimes accept
And
even
you just need to-
-2 or something.
Yeah, you just need to reassure them, and there's more chair time. Tell them that by about 3 months it settles down, and it will eventually settle down.
But do attempt a full cycloplegic correction.
Thank you, sir. Thank you for the excellent talk. Then we'll move on to the one of the prolific phaco-refractive surgeons from Chennai, Dr. Arulmurthy Varman, sir. He'll be talking about his experience with the newer version, that is Vizumax 800. Over to you, Dr. Arul, sir.
Thank you, Kudlu. We've been using the Smile platform has been available commercially for about 10 years in the market. And we've been using the 500 for about 8 years. In the last 8 months, we've gone on to the Vizumax 800. So what are the advantages of Vizumax 800 over 500? Pupil centration can be done both manually by the surgeon. Sorry, we'll go by what happens with Vizumax 500. Pupil centration had to be done only by the surgeons, depending on the centration on the pupil. So that had depended quite a bit on the cooperation from the patient. Second, there was cyclotorsion compensation lack. There was no cyclotorsion compensation at all. Yes, Sri Ganesh and his group had given a way of doing a manual cyclotorsion compensation, which was reasonably good. So other third point was the laser was a little slow. It took about 28 seconds to go on, and the patient could become uncooperative and you could have suction loss. So this is what occurs with the Vizumax 500 to show you how the docking goes on. Another issue with the Vizumax 500 was that the optics, light, and the microscope were such that the pupil was not clearly visible right until you almost docked. And that was one big issue. Sometimes we use light from the side to give us a centration. And the time taken, this is real time. This is the time it takes for it to dock and then start. As this goes on, the fixation light for the patient starts to get blurred once the laser is going on. At this point, the patient can panic, suddenly think that he or she is not seeing anything, try to move around, a loss of suction can occur. So you'll have to inform the patient about this and keep talking to the patient right through. With the Smile Pro or the Vizumax 800, things are different. We are ergonomically used to bring down the microscope onto the patient instead of bringing the bed up. In Vizumax 500, the microscope is fixed, the laser source is fixed, the bed that goes up and down. While here you're back to what you're used to in cataract, where you're using the microscope or the laser source, which goes up and down, the bed stays fixed. So laser application here takes only about 8 to 9 seconds, as opposed to 28 seconds in the 500. Pupil centration is addressed as of now manually, but if pupil centration aid is given by the machine, data can be straight away taken from either the IOL Master 700 or from Sirius. And the center of the pupil is already marked. And when you go on to doing it, you'll find a central yellow dot and a green dot that is for the center of the microscope, and a yellow line that tells you that you're away from it. You shorten the yellow line, get the green and the yellow on each other, and you're perfectly centered. Cyclotorsion compensation now is manual. You can mark 0, 180 on the slit lamp. And once you've going to start the laser after docking, you can now turn the optics so that the visual axis or the axis of treatment of the cylinder coincides with the axis of the cylinder perfectly. Very soon you'll have automated cyclotorsion compensation and also automated corneal centration. This is the Vizumax 800 that you see. You see that line. You shorten that line and get the green dot onto the yellow dot. Then you're perfectly centered. Number two, you notice that the pupil center, pupil is marked out by the machine. That gives you another added advantage. The pupil center also is seen very clearly on the microscope. So all this put together give you absolutely perfect centration. If you notice, this is the mark that is made preoperatively for the 0, 180, and this particular axis was 0, 180. You can turn the optics to make the axis of treatment coincide with the axis of marking that you have done. So you get perfect alignment each time. So the time taken now is only 8 seconds here. So to conclude on the basics, VisuMax 800 is more ergonomic. You get better docking and centration. Cyclotorsion compensation is possible now manual, faster laser application. But end of the day, you have to have the proof of the pudding is in the eating. So we did a study, which is a very small number, comparative data on 72 eyes. All data was absolutely comparable between the two sets. So one set, the group A was done with the VisuMax 800, and the group B was done on the VisuMax 500. So all patients were of similar age, and they're all age and sex matched, and the refractive error matched. And all of the VisuMax 800 patients, the toric alignment was marked preoperatively, and the adjustment was done peroperatively. So when we look at what happens in the A group, that is the VisuMax 800, you find that everybody got, none of the patients had any loss of vision. Actually, 3% of patients had 1 line to 2 lines improvement in vision. If you look at the grouping of the results on the spherical equivalent, this is a dream graph. It's absolutely tightly packed. Nothing falling out outside even 0.5. So that was absolutely brilliant. All patients were within 0.5 of the expected refractive outcome. Nothing was outside 0.5. Stability over 3 months was perfect. There was a short-term study only that the stability was 3%. So safety is fantastic. Nobody lost any line of vision. 100% got back 6/6. Actually, 3 patients got 2 lines better. 1 patient got 1 line better. Close, very close packing of the outcomes, the refractive outcomes. Now, when you look at the cylinder alone, again, it falls well within 0.5 all through. 85% fell within 5, the degrees we're looking at here. 85% fell within the intended correction degree between -5 and +5 degrees, clockwise and counterclockwise. That means 5 degrees only was off in 85%. In 15%, it was within 10 to 15 degrees. Compare that with the VisuMax 500. Apparently, the results appear same. The safety is same. 6/6 achieved 100% of patients. But here, we had 3 patients who had 1 line loss of vision. That means these patients had 6/4 or 6/5, and they dropped down to 6/6. So this is what you have to understand. This is also closely packed. It's not significant statistically. When you look at the stability, it's over 3 months, absolutely stable. Now, you look at the close packing. It is not as closely packed. The refractive outcome of cylinders is not as closely packed. You refer back to the older picture, you'll find here, this is again spread out. It goes right up to 15 to 25 degrees of error, which is possible. So that is what explains the results that Chitra got on the VisuMax 500 vis-a-vis the Contura, where the Contura does the alignment perfectly. So when you do the alignment perfectly, when it is done automatically, the results are much better. So now, to put it in a colloquial term, very soon VisuMax 800, when the automated the centration, the automated cyclotorsion compensation comes, it will beat the pants of Contura. This is the vector analysis. You will find the vector mean analysis was 0.22 in the VisuMax 800 group. It was 0.37 in the VisuMax 500 group. So we'll skip all of these. So as a study, finally, the visual outcomes were not significantly different, but there was definitely a difference in the accuracy of the cylindrical outcome in the VisuMax 800. And that is what we're looking forward to. So conclusion is cyclotorsion compensation and SMILE improves outcomes when treating myopic astigmatism. The new platform will probably give you much better results, and we need longer term studies with larger groups to get absolute truth of the matter. So finally, quick laser application, perfect treatment centration, cyclotorsion compensation are the icing on the cake. What is the future? Very, very soon, in a few months, we'll get automated centration taking data off the IOL Master 700, automated cyclotorsion compensation with the same data. Hyperopia treatment, as Sri Ganesh said, is just probably about a few weeks away. Mixed astigmatism are probably a few months away. Custom treatment and Presby Smile are all on the pipeline, and we should have it within a year or two. So these are the references. There are plenty of references for all that material that I put out, and they all coincide with our studies. Thank you.
Thank you, sir. Just we continue the discussion, and I now invite none other than Mother of Smile, Dr. Rupal Shah, probably the first person to start Smile in the world. In fact, even in India also. So, Madam will be talking about something newer lenticular procedure in 2023, where we stand. Over to you, Madam.
Thank you, Dr. Kudlu. I thank the chairs and all my friends sitting here for giving me this opportunity. So I'm going to be talking about newer lenticular procedures. Where do they stand in 2023? Could you change to this one, please? I'm a consultant for Carl Zeiss Meditech. I helped in the evaluation of the SMILE procedure and the development. For the uninitiated ones, what is the lenticular extraction procedure involved? It involves carving out a lenticule within a central stroma and extracting it out from a very small incision. And the lenticule forms the effective refractive change in the eye. So there is no excimer laser use, no ablation carried out. Instead, a physical lenticule is removed, so the intact corneal tissue is removed from the stromal bed. It was first introduced in 2008 and commercially available by 2011. In the last decade, over 5 million lenticule extraction procedure has been carried out, which says a lot about itself. So from the time we introduced the small incision lenticule extraction in 2008, the advantages of lenticule extraction has been clearly evident, that there was only one laser involved instead of two lasers. There is no flaps or no flap-related complications, much smaller corneal surface incision, thus leading to less dry eye profile and better biomechanical stability promised. Much less total energy input in the eye means that there is going to be less inflammation and consequently a better stability of treatment. And true optical zones with maintenance of the aspheric shape of the cornea, leading to fewer induced aberrations in the eye. So these are really great advantages of a lenticule extraction procedure. The SMILE procedure was done as 4 cuts, where there was a posterior lenticular cut followed by a side cut, followed by the anterior lenticular cut, which would go a little beyond the posterior one, ending in a small incision. The new developments in the last 2 years is that till now, while there was only one platform available, which was the VisuMax 500 from Carl Zeiss, the availability of a single platform was disadvantageous for both doctors and patients. Some of the cost benefits were negated by the high cost of the treatment packs and treatment licenses. And once you buy the laser, there is no other choice but to continue buying the licenses. Otherwise, you've wasted your money on an investment on the laser itself. Innovations were restricted to a particular platform's limitations. And since imitation is the best form of flattery, now newer platforms are available. So now we have 4 other platforms to work on doing the same thing. So while the source of laser wavelength is still remaining infrared, the 1043 nanometer sticking to the Carl Zeiss 500 and the 800 Pro, we have the Zemer, the Bausch & Lomb, the Schwind and the Elita by J&J as 1030 nanometer and the Elita to be 1040. The laser pulse repetition rate has what has changed in the newer platforms, and it's gone much higher and up to almost 10 megahertz, making the procedure much more refined and also smoother dissections. The energy per pulse is also now going on to less and less. Laser cut time is ranging between 10 seconds to around 30 seconds in different platforms. The patient interface is the one which was the factor which was not allowing further investigation on the other platform because it was patented. But now with flatter contact glasses also, they are able to do a good extraction of the lenticule. Cyclotorsional compensation was the one that was lacking in 500, which is present in all the other newer platforms. So as the inbuilt centration system, and the lenticular geometry varies slightly from platform to platform. Now the different platforms which I'm going to be talking to you about, I have not personally tried myself, but I've got the information from the initial users. So I would like to thank Dr. Kumar Doctor and Dr. Mahipal Sachdev and Dr. Raghav for compiling these for me. So CLEAR is corneal lenticular extraction for advanced refractive outcomes. It is a platform which is done on the Zemer laser. The salient feature about this is that there are 2 incisions instead of 1. The first incision goes to the anterior plane, the second one goes to the posterior plane, thus avoids the lenticule sticking on to the surface, and that is an advantage for people who are learning it new. There are, like other new platforms, compensation for cyclotorsion and different centration options, and it has now worldwide experience with multiple users and showing pretty good results. This is how it works. So this is the video courtesy Dr. Kumar Doctor. So the first incision, you can see it's doing the upper lenticular dissection. The second incision on the left goes to the bottom plane, and then you can separate out those both planes from different incision sites. So sometimes if the lenticule is getting stuck on the surface up, this will prevent it from happening. Having said that, you can still, from the lower depth that you go, enter the upper depth, so you have to still be careful while you do the dissection. The other incision, you're going in the other plane. And then once the lenticule is separated, you can remove it from either of the incision sites. The Visumax 800, very nicely described by the previous speaker, has easy cyclotorsion alignment, is very fast. It's probably the fastest done lenticular extraction procedure today. And it causes an easy centration and change of centration if you want after docking too. The ELITA system or the silk, now really non-ophthalmic exotic names are given to all these procedures today. And it's a little non-intuitive, but they are quite interesting. So SILK stands for small incision lenticule keratomileusis, done by the J&J laser. I'll just take half a minute more. It's a new investigational femtosecond laser design. It's not yet available. It's not FDA approved and also not outside USA. It's still getting investigated. But it's again a next generation lenticular procedure. The indication is myopia with myopic astigmatism up to -12 and up to -6 diopters of cylinder, probably the highest range. It causes, the salient feature here is it causes a biconvex lenticule shaped design to preserve corneal integrity and improve nerve generation. And the treatment time is also really small, of about 16 seconds. And you can do post-docking centration and cyclotorsional adjustment, and giving consistently smooth and easy lenticule removal. So we are looking forward to a bright future for lenticule extraction. The availability of different platforms will expand the potential pool of physicians and expand options for patients. And as a collective, our bargaining position would be improved with hardware manufacturer. And innovation in this area will expand the possibilities and will not be restricted to the limitation of only one platform. And before I end, I would like you to raise your hand. One hand, please. Please raise your hand. Thank you. And can you raise it a little more? So we could raise it more, right? This is something which is known as Kaizen, which is a Japanese concept that however you try, you can still do better. And this is collective innovation which is going to lead us still to a better outcomes. Thank you very much.
So we have next speaker, Krishna Pradat Kudlu, who's going to talk about presbyopic lasers, the way to assess these patients and do treatment planning. Kudlu has probably the maximum experience and started very early doing presbyopic laser correction on the cornea. So over to you, Kudlu.
Thank you, sir, for the kind introduction, sir. So this is my financial disclosure. I'm consultant for Carl Zeiss India. So how would presbyopic treatment going to affect your practice? Because most of your patient, if you take the data daily, are presbyopes. Even parents and relatives of LASIK patient come to us and ask, do you have any solution for us to get rid of your glasses? Even percentage of emmetropic presbyopes also come to us and asking that, will you do for something about get rid of my glasses? Even patients already underwent cataract surgery, still they doesn't want to wear the glasses. So these are the principles used to correct presbyopia. Either we used to do one eye for distance and other eye for near. There was some of the examiner machine, they used to do something called multifocality laser presbyopic refractive surgery. Even you can do increased depth of focus, what we do in camera inlays, or you can think about combined approaches. So this is overall picture about what are the options for presbyopia. Even some of my friends even tackle sclera by putting scleral implants and doing laser rays procedure. You can tackle cornea, either you can do presbyond, you have got even supracore, intracore, you have got even some of the corneal lenses also, you have got even corneal inlays. Even probably around 7-8 patients, still patients are coming to me. People used to do even conductive keratoplasty. Even some of my friends still practicing presbyopic contact lenses. Coming to the IOL, there are a lot of IOLs are in the market. Probably the most common one is nowadays with the trifocal and EDOF lenses. So I will not talk about much about the corneal inlays. We used to put in a non-dominant eye, which gives an increased depth of focus. There are different corneal inlays available in the market, still become more and more unpopular because of slight reduction in the distance vision, glare and halos, and reduced contact sensitivity. This is about the scleral series complex modification, so I will not talk about. Normally what they do, 4 PMMA segments are implanted after creating a 4 incisions with a sclerotome in the quadrant of the sclera that have a effects for near vision. So laser rays procedure quite popular in Taiwan. One of my friend who did more than 2000 patient, what he gives a YAG laser ablate which can ablate around 600 micron, which will have a effect for near vision. So Presby LASIK, I think probably Dr. Srigani started quite long back. Then due to we have to repeat this treatment, and there is a reason it has become much quite unpopular. So this is about the central Presby LASIK. Now comes the Presby Max. I think few of my friends still doing this treatment. Basically, it's a biaspheric multifocal ablation with a micromonovision. So AMO Physics also started with something called presbyopia, especially for hyperopia. Now I think they stopped this treatment. So these are the problem with the presby LASIK: initial compromise of the distance vision, adaptation problem, and a night vision problem. They used to complain. Then this is one more popular presbyopia treatment, that is supracore. That is with the help of, I think, the Technology 217. What exactly they do in supracore? Actually, they treat both the eye for distance and both the eye for near. So basically it was more popular for, especially for hypermetropic patients. So intracore, they started initially with that. Now they are the Bosch and Lomb stopped doing this treatment. So let me come to the main part of this talk about the press bond laser blinded vision. I've been doing last 13 years. Basically, very important about the refraction, dominant eye testing, and the routine pre-op evaluation. This is the principles. Basically, it's a monovision principle, depth of focus to reduce the anisometropia, multifocality from epithelial lenticule, retinal imaging, neural summation, blur adaptation, and neural separation. So what we do, we make the dominant eye emmetropic and make the non-dominant eye myopic by 1.5 diopters, along with by creating a spherical aberration in both the cornea. By doing that, you will have normally there is something called blind zone where the vision from both dominant and the non-dominant eye meets up and the binocularity retains. Basically, more than 97% of the patient actually tolerate this. So coming to the pre-op evaluation, who can undergo press beyond any patient myopia? Even I have done up to 8 diopter depending on the Pachy value. Hypermetry up to 5 diopters I have done. Even I have done a large series of patients I have done in emmetropic. Even astigmatism up to 4 diopters. But make sure that there is patient don't have the cataract. So my chair time for all my presbyopic, the patient, those who want to undergo presbyopic laser refractive surgery is minimum 45 minutes. I myself take the history, detailed history about medical history, whether they are having dry eye symptom. I work up everything. Once I work up, then I even look for a pupillary reaction, ocular motility testing. I myself do the refraction. So, of course, all refractive patient, you have to do proper indirect ophthalmoscopy, make sure that the retina is also normal, and proper dry eye workup is mandatory. Once you know that, I think uh, even though a lot of optometrists working with me, this particular test I myself do, both the eye check for distance vision. Once I am through with the distance vision, always make sure that it is duochrome balance. And most of the refraction, even with the myopulse, I do cyclopedic refraction. Once you know that okay, it is duochrome balance, then my next step to know about the dominant eye. So make a small aperture in the both the hand. Tell him to see for distance. Normally I keep it at 636 or 624. Tell him to see, then tell him to get the both the hand together near to the eye. Whatever the dominant eye, normally patient exactly come and focus in front of that. You can cross check by closing each eye. Make sure that you will know exactly which is his dominant eye. Once you know that which is his dominant eye, then from non-dominant eye, normally you add plus 1.5 diopter. That is something called, the test is called micromonovision. Then tell him to read with the same correction on for distance and tell him to read for near vision. If the patient doesn't complain of any cross blur or double vision, these are the patient do really well. If the patient complaining of any cross blur, sometimes you may have to repeat this. Still they complain, these are the patient, I am not taking them for any of the these laser refractive presbyopic surgery. So coming to, there are different tests to note ocular dominant eye testing. Like see why I'm telling you, those who want to really do even cataract also, to some most of my friends nowadays started putting EDOF lens in the same concept. So you need to know ocular dominance very well. By there are different tests like shooting stimulation, pointing stimulation, but knowing dominant eye is very very important. I'll just take 30 seconds. So basically, some of the patient will have a no clear dominance. So some patient will have alternate dominance. You have to be very careful while treating. So once everything over, then the whole data has been transferred to the CRS master. I'm still doing with the MEL80. But this is one important test I do. I trace, make sure that patient doesn't have cataract to look for dysfunctional lens index. I enter the vascular detail also. This is about the procedure, which is quite similar to the any of the procedure with the femto. So I'm not just similar to the any of the femtorefractive surgery. So once the treatment under Visumac done, then it has to be patient had to be shifted under the examiner table. Then the treatment is quite similar to what you are doing the refractive treatment. These are our results for 500 patients and who had come for last 5 years of follow-up. So none of the eyes lost more than half a Snellen's line of vision when compared to the pre-op corrected visual acuity, and majority of the patient maintain functional stereo acuity with no loss of contrast sensitivity. This is about the recovery phase. It has got physical adaptation phase and neural adaptation phase. So most of the patient recover immediately. I think I am happy to be see Dr. Sri Ganesh has been operated for presbyopia almost 7 years before. Still he is very very happy. So I think only few patients take more time for longer adaptation. In end, it is a people depend, not depend upon the people size. All our patients has a very good intermediate and near vision. Adapted more than 97% of the patient adopt this treatment. If you compare all this treatment, if your patient don't have the cataract, probably presbyopia scores a more mark over any of the treatment. Probably the best available presbyopic treatment available till date. Thank you, Anandal, for the kind listening.
Thank you, Dr. Kudlu. That was very nice. So I think the market will expand and we will see more and more treatment for presbyopia being done on the cornea, and probably presbyopia is going to be it.
8 years. It's 8 years since I underwent presbyon live surgery during my conference. Dan Reinstein did it for me, and I'm still maintaining 6.3 for distance and J1. Now on glasses after that, it's been 8 years. So, I mean, that is the proof of the pudding. And once you get it done yourself, then it's very easy to convince your patients. You say, see, I got it done 8 years ago. I'm not wearing glasses. I'm doing surgery. I'm reading everything. Then say, okay, doc, fix it tomorrow. I want to get it done.
In fact, it was my pleasure to be moderating that surgery of yours.
I did it for my for my husband 12 years back. He did need one enhancement 4 years back, but he's still without glasses, so it does work.
So Dr. Shri Ganesh has become the national representative of presbyopic treatment in India.
It is my pleasure to call upon Dr. Sanjay Chaudhary. He has been doing phakic IOLs from a long time now, extensive experience with phakic IOLs, and he will be talking on how to do the perfect IOL, phakic IOL procedure.
Thank you, Dr. Shri Ganesh. So, thank you, Dr. Kundlu, for giving me this opportunity. And when you said perfecting a phakic IOL in 2023, I was wondering what exactly are we talking about in 2023? What is the latest? What are we thinking? So, I realized that even in 2023, people are still, they are adapting to phakic IOLs. Is coming up, but not the way we thought it is coming up. There still are fears in the mind of a common ophthalmologist about phakic IOLs and its complications. So maybe it's time we should alleviate those fears. So over 15 years, some of us here have implanted several thousand phakic IOLs on the dice even. We have used all types of phakic IOLs, be it the Star, the Care, the Biotech, the Medinium. We have faced all types of complications in this period. And we have put our minds on how to prevent these complications. And we have been successful to some extent. How? The two main fears still lurking in the mind of most of the ophthalmologists who want to transition to this technology is the fear of glaucoma and the fear of cataract. Let me see if I can help you out a little bit on these two counts. First, the fear of glaucoma. If ICL is inserted under visco, and which is the most common way of inserting a phakic IOL, there is a disadvantage, and the disadvantage is that visco, which is trapped between the haptics and the sulcus at the periphery, cannot be removed fully. Residual visco can clog the trabecular meshwork and cause a post-op rise in IOP. And this is fairly common. I'll show you the video and show you the reason why this is fairly common. Now, in this case, I had thoroughly removed the visco for a minute, but when I took my irrigation aspiration out, the IOP came down and the vitreous started moving in under the ICL from the periphery to the center, and through the central hole, it kept coming out and out and out and out and out.
See, despite a 1 minute of irrigation aspiration, there is still visco there, which was trapped in the haptics. And I do a little irrigation again to take out this visco, and the moment I come out again, the pressure comes down and then more visco starts coming out. So you can imagine how much of visco is still getting retained even after a thorough visco removal of 1 minute. So, Dr. Shri Ganesh was the pioneer who talked about putting ICLs under Helon GV. And it is doing very well. Even I did that. I was very happy with the technique. Advantage, ease of insertion, chamber very well maintained, and the whole thing comes out in one bolus because Helon GV has molecular chains. So there is no blocking of the trabecular meshwork and no early rise of IOP. It was a fantastic technique, but in one case I encountered a problem. And I probably attributed it to this. Maybe Dr. Shri Ganesh may be able to correct me. I felt that there was a rise in IOP and probably there was some kind of a break in the molecular chain trapped between the haptics and the sulcus. So it is not necessary that the whole thing has to come out in a bolus. Something could break in the molecular chain and still get trapped. And those residual pieces may dislodge, come towards the trabecular meshwork and block the trabecular meshwork. And these pieces dissolve very slowly. So the IOP rise may be prolonged. I may be wrong in my assumption, but I assumed that was probably the reason. So I thought, why not do away with all the viscoelastics? And I went on to a technique called hydroinsertion. Hydroinsertion has its advantages because you are not using any viscoelastic. The viscoelastic is only in the injector, which is minuscule. And it is just floating around that minuscule threads. So it gets sucked out very easily with minimum irrigation aspiration. And early rise of IOP is virtually non-existent. In my last 3,000 cases over 4 years, I have not faced even one case of rise of IOP. So that is a very strong testimonial that says that the hydroinsertion works very well in this situation. No irrigation under the ICL has to be done because we know and it is documented that if you go under the ICL to irrigate, there's a risk of cataract, which is not here. Surgery time is reduced to just 5 minutes. Whole surgery is done with just 30 ml of fluid. So minimum irrigation, your corneas are crystal clear the first post-op day. So it is a win-win situation doing insertion under hydro. So here is my present day hydro insertion technique. And just see the ease with which the whole process is done. ICL injected, IOP is just 40 here. Irrigation aspiration for just 5 to 10 seconds. All the viscose strands are over. Tuck in, bring the ICL into the right axis and tuck. It looks very simple. The whole procedure done in just 5 minutes. 30 ml of fluid. No visco, no early rise of IOP. I am kind of sold to this kind of a procedure, and that is why I talk about it. But then the problem with people is that early users, beginners may face a problem. The second fear is the fear of cataract, the bigger fear. Can I help you reduce your fears on this count? So if ICL is inserted under visco, the disadvantage is that it needs a lot of irrigation to get that visco out from under the ICL. Excessive irrigation or irrigation under the ICL can cause a cataract. So here's the case. First post-op day, there was this kind of a haze, and this kind of a presentation on slit lamp. And initially, when you were talking about this some 10 years back, we said this is visco on the crystalline lens. It looked typically like a visco on a crystalline lens. However, these dissolved over time. So we looked up the literature when we had a couple of cases like this, and the literature said that there could be anterior subcapsular vacuolar changes of the crystalline lens, and the conclusion was that it is because of direct irrigation in that space between the ICL and the crystalline lens, and these are transient, and there is a spontaneous reversal. We were happy. There was spontaneous reversal. We were encouraged. However, we had another different scenario, a diffuse anterior subcapsular cataract, and we
Sanjay,
waited.
we have one more speaker, so.
Okay. Yeah. So this we expect would dissolve, but it didn't. It kind of collected towards the center, and it developed into a frank cataract, and it had to be removed as a cataract. So the inference was, do not irrigate between the ICL and the crystalline lens. And it is not just the anterior vacuolar changes, but cataract can also happen. So the last advice is a small video clip that what I advise to the beginners, that instead of doing under hydro only, you do it under visco, place the ICL under visco on the iris, then remove the visco when the ICL is over the iris, because now there is a huge gap between the ICL and the crystalline lens, and there is no visco getting trapped in the haptics of the ICL, and then you tuck it in. Thank you so much.
Thank you, Sanjay. And for paucity of time, we'll go on to the next speaker. It's my pleasure to invite Dr. Pooja Kamar, who's a senior consultant in Narayan Netralaya and who's doing a lot of cutting-edge research work at NN, to speak on gene therapy in refractive surgery. All I know about genes is to select the right partner so that your children don't wear glasses. But she's going to tell us more.
Thank you, sir. Thank you. At the outset, I would like to thank AIOS, Kudlu sir, and the entire refractive surgery committee for having me here. So I'm going to be very quick and just tell you right to the point how it's going to be useful in future. So this is something which is lysyl oxidase. Lysyl oxidase is something which holds your corneal stromal collagen into place. But if the lysyl oxidase, the purple dots, what you see, it's on the lower side, the collagen starts slipping away. And that's when you develop ectasia or keratoconus. And if it's on the lower side, your keratoconus disease starts progressing. And if it's a refractive surgery patient, it can develop ectasia after your surgery. So this is what you have to keep in mind, is why lysyl oxidase is important. So we have proven with multiple publications and research projects where if the lysyl oxidase levels are lower, the keratoconus disease keeps progressing. And also after cross-linking also, you have cross-linking, but the cross-linking effect can fail because of the lower lysyl oxidase levels. And we were the first one to report that post-SMILE surgery, a patient with normal topography and biomechanics underwent SMILE. But after SMILE surgery, patient developed ectasia. So if patients developed ectasia in LASIK, we cannot evaluate why it happened. But in SMILE, we had the lenticule, and it did show that the patients had lower levels of lysyl oxidase and collagens to begin with. So the question here is, can we modify this lysyl oxidase gene with the gene therapy in corneal ectatic disorders? So we at NN have developed a class 100 facility where we can develop our own vectors which can be used for gene editing or gene therapy. Now, gene editing is nothing but it removes a defective gene and it replaces it with a normal gene. That is what gene editing is, and that's where the AE vectors come into play. Now, there can be different modes. There can be topical drops, there can be intrastromal injections, intracameral injections, or subconjunctival injections. But we wanted to study that whether the topical drops or intrastromal injections can help in modifying this lysyl oxidase gene or enzyme. So we did a lot of studies on animal model and lenticule where we injected the lysyl oxidase vectors. Just to simplify, what we found was that if you inject this lysyl oxidase vectors intrastromally or as a topical drop format, your lysyl oxidase levels here, you can see in this graph, do increase compared to that of controls. And your collagen, which is also necessary to maintain the strength of the eye, also increases. But more interestingly, what happens is the inflammation. Inflammation is always higher, and it is responsible for keratoconus disease and the progression of disease, or it's also involved in ectatic conditions. So if you can control the inflammation, you are halfway through. So lysyl oxidase therapy just not only increases the lysyl oxidase levels and the collagen levels, but it reduces the inflammation also. And we found this results consistently in human donor corneal lenticles, the human corneal mouse model. So next what we did was we want to start this therapy with, of course, DCGI approval and regulatory approvals on patients. So before that, we had to have the right technique of how to use this lysyl oxidase vectors and how to inject them. So we create these pockets using IFS. You can also use other technologies to create pockets like how you use for Intax channel. You open them and then you inject the vectors into this wound and then you seal them. What we are seeing early results is that you can see here how the gap is. That means the collagen and the lysyl oxidase is on the lower side. And when you inject these vectors, they start becoming tighter with one therapy. And not just the collagen and the lysyl oxidase starts becoming tighter, the strength of the cornea also increases when you inject this lysyl oxidase vectors. So the future is, of course, as refractive surgeons, you have to do refractive surgery. You cannot prevent ectasias. But if you know that your lysyl oxidase or the collagen levels are on the lower side, or if your patients do develop ectasias after that, lysyl oxidase therapy, a gene-based therapy, would be a potential treatment modality for these patients and for keratoconus patients as well. We have already published this gene therapy guidelines for India. So it will be soon coming to India with a Make in India product. So it will be cost effective for the patients as well. Thank you.
Yeah, Pooja, I have a straightforward question.
Yes, sir.
Can this replace Smile Extra?
Sir, that would be a path forward. At this point of time, we do believe it will. So you'll just have to use drops in topical format, but it will need at least 5 to 7 years of work before we can say that.
The second question would be just offhand, if it's going to be a drop therapy, why not use this for every patient after every refractive surgery?
So because it can have a negative effect also. If your lysyl oxidase and collagen are optimal, and if you put them, your refractive surgery, any surgery do, especially your smile extras and PRKs, they will land up into scarring and haze. So scarring and haze post-surgery. So you have to have it in an optimal level. So only if it's on the lesser side, you probably would do it.
Can you prevent progression of keratoconus with this?
Yes, ma'am. That's the idea.
So thank you, Dr. Pooja. Naran Netralaya has always been at the forefront of cutting-edge technology and contributing a lot to the development. So
thank you, ma'am.
Thank you very much.
Thank you.
With that, we come to the end of the session, and we would like to thank all the people sitting here still till the end for being such good audience, and the faculty members to be able to give such good lectures. Thank you very much.